This information is not intended to substitute for independent professional judgment of the treating provider in the context of treating an individual patient or developing practice policies and procedures. It's my distinct honor to introduce our moderator today, Dr. Douglas Delaney, who's a professor of medicine and oncology at Stanford, former medical director of Stanford Cancer Center, and specializes in the treatment of breast cancer. He has a special interest in quality and value of cancer care. Dr. Delaney is a past president of the American Society of Clinical Oncology, a founder of the ASCO Quality Symposium, a co-author of the ASCO Value Framework descriptions, and instigated the ASCO Clinical Big Data effort, which is now CancerLink. He has received the inaugural Ellen Stovall Award of Leadership in Patient-Centered Care from the National Coalition of Cancer Survivorship, and he has held leadership positions at University of Michigan in the past and has won awards, has numerous publications, well known internationally, and he will be introducing the other panelists. But before then, can I have the next slide, please?
Great. Thank you, MJ, for that kind introduction. And it's always a pleasure to collaborate with you. And good morning to our audience from around the world. It's just beginning the day here in California, and the first day of fall. We have a distinguished and I think very interested and engaged panel this morning to talk about quality and how the COVID-19 is impacting our not only measurement of quality, but more importantly, how we deliver quality cancer care to the patients we see every day. So our three panelists, in the order in which they'll speak, are Dr. Shahina Dawood, who's a consultant medical oncologist and associate professor in clinical oncology in the United Arab Emirates. She trained in North America at McGill and MD Anderson and was awarded multiple Scholar in Training Awards and ASCO Merit Awards. She has served as an editorial fellow at the New England Journal of Medicine, has a master's in public health from Harvard School of Public Health. She's published over 80 papers, including book chapters, is a reviewer for multiple journals, and currently leads the Oncology Clinical Trials Program at the Clinic City Hospital in Dubai. She is president of the Excellence in Oncology Summit that is held annually in Dubai, and is co-president of the Asia Pacific Breast Cancer Summit and Asia Pacific Gastrointestinal Cancer Summit, and has recently launched a BRCA Forum and MENA Immune Oncology Summit. Secondly, Dr. Giovanni Variani is a clinical oncologist at Sírio-Libanês Hospital and São Paulo Cancer Institute in Brazil. He is a member of the Quality Committee of the Brazilian Society of Clinical Oncology and a member of our ASCO Oncology International Quality Task Force. Dr. Deidre O'Mahony graduated from University College Cork and completing specialty training in medical oncology in Ireland and a master's in molecular medicine from Trinity College Dublin. She moved to the United States, where she had a postgraduate fellowship at the National Cancer Institute in Bethesda, Maryland. She continued there as an attending, and in 2008 returned to Ireland to a consultant post with a specialty interest in breast, lymphoma, and sarcoma. As a long-standing member of the Lymphoma Forum of Ireland, she was nominated as president last year, and she co-founded the Irish Sarcoma Group and advocates for streamlining of sarcoma services in Ireland. She has been active in clinical, academic, and research programs. She is the Irish Society of Medical Oncology president and committee member of the ASCO International Quality Task Force. So with that, I welcome you all, and we'll turn it over to Dr. DeWood. Thank you. Now, in reminder of questions, we will be glad to entertain, we and the panelists will be glad to entertain questions. please use the Q&A box on your WebEx screen. So now, Dr. Doerr.
Thank you, Doug, and thank you, MD, both of you, for a lovely introduction and for putting together this important webinar and giving me the space and the opportunity to be able to give our UAE experience of the importance of maintaining quality during COVID-19. Next slide, please. Just like any other country, we also faced the pandemic through March all the way to May, and you can see that from the slide over here. This is data that's been derived from the Ministry of Health publicly available data, and you can see that we actually peaked at April and May with the highest number of deaths at that time, although the associated mortality rate was not that high compared to other countries, and we are beginning to see a second wave that's developing. Next slide. From the very beginning, we knew we would have a number of challenges in terms of when we went through that pandemic. We all knew that this was the first time we were facing something this horrific. And as a team, we identified those challenges. The first was that we had a large cohort of UAE national patients who were being treated abroad, who were all being repatriated back to the UAE. We knew that we wanted to limit visitors to the hospital, and culturally that was very difficult. Implementing teleconsultations had its own inherent challenges, and that included the acceptance of both physicians and patients to it. And of course, there was this huge fear of patients coming to the hospital for any sort of therapy, including cancer therapy. Next slide. So we put together a set of goals right from day one, and that was we wanted our diagnostic, surgical, and therapeutic services to be kept functioning specifically for our cancer patients, although there was a significant decline in our elective patients. We wanted to maintain uninterrupted therapy for both existing and repatriated patients, which was a challenge in itself, especially when patients were being repatriated and put into quarantine as soon as they reached the UAE. But we did have channels and pathways to assist that. We wanted to be able to maintain standards with chemotherapy administration, especially since we knew that stocks were going to decrease. And so we had policies and procedures in place to be able to counteract that. We wanted to provide a safe environment where the risk of COVID was going to be kept to a minimum. And so our overall goal was to not negatively impact the prognostic outcome of our patients with either early or advanced stage cancer. Next slide. So to do that, from day one, we wanted to build a sort of a cancer fortress. A little bit of reorganization was needed, and we had all our facilities that cancer patients would require in terms of their diagnostics as well as treatment was put into an independent building. We had fever screening clinics at multiple points in this building. We had a strict no visitor policy, although later on we had to relax this a bit because of the cultural policy that we have over here. We had a rapid adoption of teleconsultation for selected patients, and we adopted a policy of monthly COVID-19 testing for both patients and staff. And we had full PPEs offered for staff during chemotherapy administration. And of course, masks were mandatory for everyone. And as you know, in the UAE, if you do not wear a mask, there is a huge fine for that person. Next slide. And what you can see here on this slide is the data that we collected for the monthly COVID testing for our patients. And you can see that the highest number of patients that were positive was obviously during the peak of the pandemic between April, May, and then it went down in June. We had both asymptomatic as well as symptomatic patients that were tested. About 52% of the tested symptomatic patients were positive. And of course, amongst asymptomatic patients, about 1.6% of patients were positive. Next slide. And of course, we wanted to be able to have our own center-specific guidelines and strategies to maintain quality. This was specifically important because, as you know, during the pandemic, we had a lot of guidelines being published all over the place, and what to incorporate and what to use in our center was paramount. So we all sat together as a team. We reviewed all the guidelines and adapted it to our center-specific cohort. We ensured that IV chemotherapy was not interrupted, although a lot of guidelines suggested to switch over to oral. We increased the usage of GCSF support as well as antibiotic coverage. And as such, we did not compromise on neoadjuvant or adjuvant therapy or first-line chemotherapy for patients with metastatic disease because we knew it was important to improve outcome. All cases were discussed on an online adopted multidisciplinary tumor board, and physicians who were asked to use teleconsultation methods had to go through a mandatory online training, and they had to complete that course successfully before they were allowed to use this mode of consultation. And what we did was we also increased documentation of all teleconsultations done, with follow-up being mandatory. And we also trained our patients for self-physical examination, and documentation of that was performed. And as such, when we collected our data, we felt that 99% of our patients actually received therapy on time and without interruption. Next slide. But despite us trying to create that ideal world where every patient is achieving the best prognostic outcome and the best therapy, we knew that there was a dilemma that we were going to face, and that we are now going to face that now, because we know that screening diagnostic clinics across the country and services that were needed to diagnose our patients with cancer were significantly decreased. And you know that the data that comes from the UK actually predicts a 20% increase in cancer mortality, mainly due to these delays. And as such, right now, the types of patients that we're seeing in the clinic are patients on active therapy who self-delayed their therapy as a result of the COVID pandemic. We've seen elective surgeries delayed nationwide, which has resulted in some patients actually presenting with advanced diseases. Screening programs were restricted. Patients with signs and symptoms of malignancy did not come forward because they were scared to do so. And as a result, again, we're seeing more advanced patients. And the overall impact is, like I said, we are now seeing patients with more advanced disease. And as such, I think, next slide. As we see the second wave of COVID coming up in terms of the pandemic, I think it's important that the lesson we've learned that it is possible to maintain quality of care even during a pandemic, and I hope the second wave will not have the negative impact that the first wave had. Next slide. To be able to achieve what we have achieved in our team, it has all been a team effort, and as you can see, we have a very cohesive team of very colorful medical oncologists and nurses and radiation oncologists and surgeons treating our patients. Thank you very much.
Reminder to ask a question, use the WebEx Q&A box. Next, we'll ask Dr. Bariani to discuss his experience and some general learnings on telemedicine. Dr. Bariani.
Well, thank you, Dr. Blaney, and thank you, Asko, for having me here today. I'm happy to be here to talk about telemedicine, why it's important to have quality metrics. The term telemedicine refers specifically to remote clinical services, while telehealth refers to a broader scope of remote healthcare services. In this webinar, I may use them interchangeably. We know until recently, there were many barriers and restrictions for telemedicine in many regions of the world, and many have now been granted because of the COVID pandemic. Regulating, credentialing, and financial barriers were major problems, but all that was made easier with the pandemics. However, how do patients know if their healthcare is good? How do providers identify the gaps for improvement? And how do insurers determine whether they are paying for the best care? The answer is Measure. Measure provides us a way to assess healthcare against standards. So in this slide, we can see a research from the Deloitte Center that surveyed healthcare executives and find out half of them thought at least a quarter of all well-being, outpatient, and preventive services and long-term care would move to virtual delivery by 2040. The majority of them also predicted that industry-wide investments in virtual health would be significantly higher over the next decade than today. Next slide, please. So why should we measure telemedicine? Despite the effort to provide qualified care, no one can see through the complexity of the healthcare system to make sure that the end result corresponds to the best patient care. Measures light the way, showing where systems are failing and where they are succeeding to help patients. The reasons for measuring it is to really understand its principles, What are the fundamentals of what makes telemedicine unique and beneficial for health? What makes telemedicine of great value to patients and providers? Measurement is assessment. You have measures so you can look at something objectively, independently, and without bias, so that you can determine, for example, what is the increase in access to care, what is the increase in timeliness for someone to receive the treatment, and so on. It's basically looking at the input to provide an output of a metric that objectively assesses what the benefits might be. In that way, measure drives improvement. Looking to performance metrics allows providers to make adjustments to care, share results, and look into causes when progress is insufficient. At the end, measure gives information to consumers as they can make their choices, and to payers that may use metrics as standards, targets for bonus, and consequently influence payment. Next slide, please. So, how do we figure out which measures can give us the greatest return in better quality for patients? First, in a complex healthcare system, it's important to set priorities and goals where more effort should be concentrated to make the biggest difference for patients. In that sense, measures should be customized to address the needs of the patients and communities. A measure must be in accordance with the principles of the organization and have no conflict from a regulatory perspective or with local regulations. It should be developed using rigorous criteria to receive endorsement, meaning it has a strong evidence base, is valid and reliable. Next slide, please. So, by developing metrics based on the concepts of a framework for areas that really need measures, the focus will be on what telemedicine can provide, what will be its impact on quality, how it improves health for population, how it reduces costs, and what its limitations may be. To intersect telemedicine and metrics, there should be an alignment with policy initiatives like many others in healthcare. And instead of developing measures for in-person and virtual encounters, we should develop a set of measurement, core measures that benefit patients and providers and drive outcomes metrics that have little to no variation. Incorporating quality and metrics into telemedicine help to improve the care provided, while also collecting valuable information that can be used. Next slide, please. Okay, thank you. So I just want to finish saying telemedicine is a modality of care rather than a type of care. This means that it should meet the same standards and quality metrics for in-person care whenever possible and appropriate. In cases where the unique characteristics of telemedicine require a change in a measure, it should be adapted rather than reinvented or developed from scratch. Instead, protocols should be developed for care coordination between telemedicine and other care modalities with the goal of preventing fragmentation of healthcare. And finally, as telemedicine usage continues to grow, it is possible to take advantage of the exclusively digital aspects of telemedicine to measure and improve engagement in assessing patients' experience in a much more efficient way. Thank you.
Thank you, Dr. Bariani. And I'm going to take when we get to the question period, I'm going to take the chair's prerogative and ask each of our panelists if there's a quality measure that we could adapt for telemedicine. So be aware. And we'll have questions from our audience, and reminder again to put them into the Q&A session, Q&A box in your WebEx. So finally of our prepared presentations, before we have some open discussion, I'd like to ask Dr. O'Mahony to talk about her efforts in getting resources and how to continue our quality work during a pandemic. Dr. O'Mahony.
Great. Thanks a million, Dr. Bellini. I'm hugely honoured and excited to be part of the webinar because at its core is the tenet that quality is the foundation upon which we build healthcare. So to start, next slide. Whether the COVID is going to be the epic challenge of the year, the decade, or otherwise, understanding the theory is vital for practical changes integral to our approach. So I think it's back to the 6 domains of quality that we need to understand. That care is safe. That's not just simply safe for the staff and for the patients. In an infectious pandemic, we think primarily about PPE or infrastructure, but we need to incorporate reviews of medications, the drugs, the routes, the schedules that we use. We need to look at risk-benefit ratios. We need to look at treatment plans. We need to ensure treatment is effective. We need to develop SOPs. We need to re-audit. We need to revert to our PDSA cycles. While the next slide says patient-centered, this actually should be, sorry, Alex, I'll go back one. This should be people-centered. It is not just the patients that are important, it's the staff. It's ensuring dignity, respect, and compassion for all staff and patients alike. For a rapidly evolving global emergency, rapidly evolving solutions were necessary, so time is of the essence. It's important that we're efficient. Considering the rocketing costs, the economic, the societal, and the personal, we need to make use of the scarce resources to produce the best outcomes. And finally, equity. No matter what the background, no matter what the situation, equal care is important. Next slide, Alex. Deming's teachings describes it best when he says, any improvement requires 4 elements. It's important that we understand the system, what works and what doesn't. It's important that we understand the process upon which the system is built, why variations come to happen. We need to understand the beliefs and the attitudes of those who run the processes, and we need to understand how to make changes. So it really is back to what, why, who, and how. Next slide, please. In Ireland, we have the we have the HSE, the Health Service Executive, whose mission is the people of Ireland can access safe and compassionate and quality care when needed. It's responsible for providing all of Ireland's public health services to the community and within the country. The NCCP, the National Cancer Control Programme, is a directorate within the HSE, which manages and organises care within that. And then the Irish Society of Medical Oncology is a voluntary body of oncologists whose mission is to support oncology practices, promote delivery of high quality, high value care, and in an equitable manner. We rapidly came together because when COVID hit, it hit everything. It hit every aspect of healthcare, not just cancer. But what was important for us as a triumvirate was to ensure that we didn't pivot immediately towards reactive crisis management. It was important that we took a strategic review of our outpatients, our ambulatory care pathway. We had to recognize that there were many units designed in many different ways, most of which were within the acute hospital setting. There was going to require a major overhaul of certain situations. If new premises weren't possible, it was trying to devise new entrances to these outpatients. We had to rapidly introduce new SOPs and guidance documents, and we need to know that these had to be capable of change on a rapid basis. The introduction of telemedicine, as we've heard from Dr. Bariani, I think has been a wonderful thing. The acute hospital care and oncology in Ireland was really not even at its infancy. It wasn't at the table at all. While we were quite expert with regard to telephone triage, that final step into integrating into telemedicine had never happened. But suddenly this was something that was embraced. It was remarkable to us, and I think this has been a global feeling, how IT barriers suddenly remarkably dissolved. I think what has been quite amazing globally is that there has been a phenomenal engagement from everybody with regard to data collection, knowing that with the association of data, that data will drive quality. Next slide, please. The title of this slide, The Key to Understand the Complexity and Keep It Simple, sounds a little facetious. Healthcare systems are complex. If they were simple, we wouldn't have inequality globally. But we have to look at each of the individual parts and then see the interplay and see if there's greater scope to adapt and to improve. We had to look at, from a safety perspective, like many others, increasing isolating facilities, repurposing other environments. Pre-assessment clinics had not been standard of care. The pre-assessment clinic had to vary depending on the situation. For some, this was a telephone evaluation 24 to 48 hours beforehand. For others, it was a fixed telephone appointment to ensure efficiencies of staff, to allow return of COVID testing where appropriate, and to allow efficiencies of chemotherapy administration and the runnings of the day wards then in the following appointments. At a national level, we looked at enhancing community services to try and aid in the delivery of ambulatory care. Treatment decisions were evaluated, and it was again a re-evaluation for everybody with regard to the risk-benefit ratio. I think communication has been enhanced by the pandemic to allow more frank and true conversations about risk and benefit. We had to look at adjusting drug schedules, administration routes, and to many other things. But essentially the goal was best care first time and every time. Next slide. There are still many unanswered questions. There are still many challenges. I really was very excited to listen to Dr. Bariani's talks and the use of telemedicine with regard to collecting data with regard to patient-reported outcomes. I think one of the most difficult things for all of us has been the suspension of cancer screening and what this impact is going to have with regard to patient outcomes and quality care in the future. The impact of surgical delays because of prioritization of other aspects, the variance in adjuvant treatment decisions and their long-term impact. I think one of the areas where Ireland has focused essentially was a rapid response on research and innovation funding. This is actually a three-phase process where the Scientific Foundation of Ireland, in concert with the government, prepared funding that was available for a variety of different projects. In phase one, there were 58 projects that had been approved, which had looked at diagnostics, biomedical studies, infection control, remote patient monitoring, contact tracing, and as such. Funding is vital, but this is one of the aspects in which we, as physicians with our patients at the centre, need to continue to fight. Thank you. Sorry, I think this is more to do with the importance, and Dr. Daywood mentioned this as well. It is not possible for us to achieve any of our goals when it comes to cancer care delivery, when it comes to the focus on quality without teamwork. And it has been remarkable to me, and I do not believe that I'm alone here, that there are many aspects that have evolved really quite quickly. We have developed new communication methods and skills. We've broken down silos between IT and telemedicine. We've adapted to ensure that we improve essentially our approaches. But mostly, I think there has been a recognition that we need not just look after the physical, it's the psychological as well, and that the team is central to any improvements and any delivery of care. Thank you.
Well, thank you, Dr. O'Mahony. We again, a reminder to please post questions in the WebEx Q&A box, and we'll be so that we can address them in the next half hour that we have together. I think it's we lost Dr. Bariani for a few minutes, and welcome back. It's ironic that the panelist talking about telemedicine was lost for a few minutes, lost a connection, which is one of the issues I think we all have with telemedicine, is getting the technical things to work. But having said that, I'd like to perhaps in the order in which we had our presentation, ask each panelist to say if there's a quality measure you would propose and find for adoption in the telemedicine space, what would it be? And also a question from our audience is, are there any generalizable any generalizable lessons that you all have learned from your telemedicine experience that might be correlated to an outcome. So first, is there a measure? And second, are there some generalizable lessons from telemedicine that you'd like to share? And we'll go Dr. DeWood first.
So a very, very important question. And like I mentioned in my presentation, one of the things that we mandated that if anyone wanted to do teleconsultation, they had to do a mandatory training course, because as you know, consulting in person is very different from consulting online. And so they had to go through that mandatory training course, pass it, and then was allowed to get online and actually start consulting with patients. And that was one of our stipulations in terms of quality control. But then we also learned very quickly that, again, talking to a patient online, very different from in person, and the consultations suddenly got very shorter. They weren't as detailed, and so documentation was something that we were worried about, and also the time spent with the patient. So we devised these forms that sort of was a checklist of have you covered these base areas when discussing certain aspects with patients. So that was one of the things that we implemented at our center to make sure that at least as physicians we could go back and say, okay, we did this, we covered all our bases, we haven't missed anything, and we made sure that we had a short follow-up to make sure that we hadn't again missed anything. And this is again adapted to the cultural part of where we are in the world, where we needed to have that connection with patients.
Thank you. Dr. Bariani?
Also, firstly, sorry for the loss of connection. Now that I'm back and answer your question, Dr. Blaney, it becomes important to understand telehealth and the various uses of it. It's not just looking through a screen. It's a variety of different ways of healthcare delivery. You can use telehealth for ICU, for ER, for stroke, for mental health services, for oncology, and so on. In oncology, for example, I would say we know patients spend a lot of time navigating the healthcare system. Some of those systems have already implemented virtual check-ins to reduce the time spent in waiting rooms, for example. For patients who do not live near a specialist, medicine allows virtual encounters with an oncologist from remote parts of our country. So it reduces tremendously travel time and cost related. Other ways could be managing side effects, and as the use of oral chemotherapy grows, remote monitoring is another example of how we could measure telehealth and telemedicine. So those are only a few examples that intersect telemedicine and oncology. We are currently seeing several services implementing health service, so it may be too early to say in general metrics for telemedicine. We need to develop from our needs and from initiatives like this from ASCO that we can move towards developing measures that can be used as benchmarking and in a national and global perspective. I think the most important aspect is to assess telemedicine quality through evidence-based measures that can evaluate access to care, access to technology, cost savings, and patient providers' experience in a way that quality measurement programs will need to adjust measures and data collection to account for care delivery.
Dr. O'Mahony.
So I would concur actually with Dr. Daywood. I think that when we introduced telemedicine, we didn't have a formal training, but we had it was kind of like a cheat sheet, which was to try and ensure that we did not make any stark omissions. And then we had a standardized, nationally, there was this standardized documentation, which would then be connected with the patient's notes, so that you could revert and ensure that you had addressed all of the pertinent issues with the patients. One of the things that I suppose I've done personally is, and I'm fortunate, sort of just in my patient numbers, is that I've had the pleasure of having one of my staff contact patients the day following. And in that contact, the two questions really that I'm asking are, one, were all of your queries answered? And number two, have there been any queries that have arisen in the past 24 hours? I'm not so certain that that is generalizable in a real busy practice, but I think that there may be mechanisms in which that could be incorporated with a questionnaire type at the end of a patient's interaction.
Thank you. So I heard training before using telemedicine. Any measures need to be evidence-based, and this cheat sheet connected to the note with follow-up shortly thereafter. Did you have any questions? I must say that I had my early experience with telemedicine. It was great. A patient didn't have to drive 4 hours to see me. I talked to her. We had a long conversation. We prescribed some oral medications for her cancer, anti-estrogen. I thought we had a great thing going. And at the end, I asked any more questions, and she said no. And then she said, oh, by the way, Doc, when do I take this in regard to my dialysis treatment? And I like to think that I've had physical exam prowess to find a shunt in her arm if I'd have seen her in person, but it's just a lesson that what is important for us as oncologists it may not be so. It's just a routine part of a patient's day, and we lose that personal. I think we lose that personal connection and that touch part of our therapy that I think is very important, and I think have provide much personal, professional satisfaction to us. So I'd like to ask, so we've talked about telemedicine. Let's think about a year, whenever, if we're past this pandemic, do you all think it's going to, in your various settings, do you think it's going to stick? Are we going to be doing more, different, or the same or less telemedicine a year or 2 years from now? And let's ask each of our panelists, and maybe we'll go in the opposite direction. Dr. O'Mahony first, then Dr. Bariani, and then Dr. DeWood.
I think we're going to get to very much a hybrid model. I think there are instances where one cannot continue without the direct patient interaction. I think currently, unfortunately, the mask actually acts as a barrier, just like telemedicine does. So I would love to be in a situation where we are able to overcome that. I would concur with your feelings, Dr. Blaney, about the importance of touch with our patients, and COVID has removed that to a degree. I think one of the interesting things is that would be to interview not just the patient with regard to their preferences, but also practitioners. There are some practitioners who will much prefer the telemedicine route, whereas and there are patients, sort of. So I think that we have a lot to learn. I'm really enthusiastic actually about sort of hearing international experiences in this regard.
So do you think we're going to be more, less, or the same in 2 years from now?
I think we're going to be, with more telemedicine, I think we'll have more telemedicine. Because I think at the moment, sort of with regard to delivery of services, we've continued an awful lot, as other practices, we've continued to administer adjuvant, neoadjuvant therapies in person. But I think that there's going to be more engagement from those patients that live a greater distance away to be involved in the telemedicine link or the telephone link. So I believe more.
So, Dr. Bariani, your turn. What percentage of, tell us about how many of your patients in your practice come from maybe more than an hour away, and then tell us if you think more or less or the same is going to be happening of telemedicine. You're on, Giovanni, you're on mute.
Well, I completely agree, and I think telemedicine just came to stay, and we're going to use more of that. But certainly, we're going to have a lot of challenges to overcome. And I will give my opinion from Brazil perspective, because all measures adopted and implemented during the pandemic were granted only during the crisis period. So telemedicine after the pandemic will require new legislation as well as new endorsements from governmental decision-making bodies. The implementation of telemedicine has been basically oriented towards the expansion and improvement of health services. However, I think this should be viewed not only by a health perspective, but should be seen as a state policy articulated with other essential areas such as economy and social assistance. It may represent an opportunity for well-being improvement in a much more broad dimension. And going to a more specific and organizational view of that, we have cultural barriers. Telemedicine is not only a medical activity, but it involves a lot of players, from health practitioners, information technical experts, to managers and policymakers. So this is an area of big complexity. And implementing telemedicine means redesigning the work process, coordination of teams, process acceptance, and all that can generate conflicts. Sometimes it's easier to accept an innovative product than implement technology and to adopt change within an organization. So telemedicine has the potential of solving major health challenges, promoting higher integration, reducing inequality of medical resources, expanding access to care. And the only way for us to have the real idea of what's behind of all that change is to get reliable information of what's being done.
So I take it your answer is more, is going to be more in 2 years from now or in the future. Dr. DeWood.
So I'm going to be completely opposite from what everyone else has said. I can tell you at the peak of the pandemic, I was doing about 8 to 9 teleconsultations per day. And I am now doing 1 teleconsultation per week. So it has significantly decreased. And I think the reason for that is, again, a cultural issue over here. And specifically, I'm only talking oncology. I'm not talking about other realms of medicine. I think the adoption of telemedicine for patients with cancer has been a little bit difficult, at least in my part of the world, because patients want to be seen physically by a physician. They want to be examined. They want to be able to talk one-on-one. They feel they don't get enough airtime with the teleconsultation services. They get more time with the physician in person. Plus, they get to see the other associated healthcare specialties when they come to see the oncologist in person, including say, for example, in our breast unit, our breast care nurse, our oncology nurse who would be administering the chemotherapy and doing chemo education. So I think those were the nuances that we needed to address. I think in the future, perhaps in the next year, we're going to see a decrease in the services of teleconsultation in oncology here. But I think perhaps after that, once we've developed that good hybrid model, then we might start seeing an increase. And I think the key is to develop that hybrid model that will allow patients to feel safe and comfortable and allow physicians to feel safe and comfortable doing those teleconsultations at the same time integrating in-person consultations appropriately.
Okay, so we had a variety of opinions from more the same and not as much as originally. So turning to quality, one of our viewers asked, much of the data that currently drives quality measures lives in PDFs, which are non-computable, as I call them, images or typed clinical notes, in other words, non-structured data. Do you think this is going to change, or are we going to get technologies to help us extract data from these sources? Anybody want to take that? Unmute yourself and go ahead.
Well, I think
So,
for sure it's an opportunity to extract information faster through technology. I think we're having an opportunity to, in real time, to acquire data uh, using technology, something that we used mail-based and paper forms before. So it will be faster.
Anybody else?
if I may take a crack to that question, maybe I can ask you a question, Doug. I mean, how much data can a physician actually input into a system and also have enough time to be able to see his or her patient? And I think that's the fundamental problem, because in order to get all that structured information that you're talking about, it takes a lot of physician time unless you've got a facility that's actually going to put all that information in it for you. And every country is different, every facility is different. So until we have a platform that, doesn't consume too much of the physician's time, I think it's possible. But until that happens, I think that will be a barrier.
So I agree. One of the things that has changed lately is we have scribes. So there's a whole new medical specialty on scribing. The scribe, it's been a she, because I use a scribe also as a standby or a chaperone when I examine female patients. The scribe has made data entry easier. I think we've missed an opportunity at my place at Stanford to standardize the data entry tasks. I try and teach, if somebody's mother died of pancreas cancer, don't dictate that, put that in a box or a structured data field so that the surgeon can see it and our genetic counselor can see it. So if we adopt scribing more generally, I think it's important that there be some sort of uniform, again, coming back to training, to use these new medical professionals. Many of them, by the way, are taking a gap year between undergraduate and medical school or some other professional school. Not every place has that workforce available, so it's going to take something. In the Bay Area, all the big health systems, Kaiser, UCSF, Stanford, and the Sutter system all have the same electronic health system. So I can see when I see a patient from Kaiser, for instance, for a second opinion, I can generally, with their permission, I can generally see the Kaiser record. It doesn't populate my record, but I can see what's going on, and the Kaiser doc, other health team, can see what we've done at Stanford. So yes, it's a information exchange to get extractable and usable, not only for quality but also for clinical care, is important. So one of our listeners or participants also makes the comment, and it sounds like resonated with what several of you were saying, that medical visits are only one component of healthcare. This building a more comprehensive network with services available to patients has resonated, sort of this hybrid model of physician and healthcare delivery. Anybody want to comment? One of our other questions came through. As medical oncologists, we can fairly easy to adopt, or not fairly easy, there are challenges, but we, in talk and pill therapy, we can adopt to telemedicine. How do we, our colleagues in surgery, radiation, and in palliative care service, how do they deal with telemedicine in your part of the world? So telemedicine for surgery, medical oncology, surgery, radiation, and other oncology. So who wants to go first?
Well, maybe I can start. So for palliative care, we actually the teleconsultation service, our online service, was actually worked very, very well. Especially, as you know, in palliative care, you need to be able to discuss and consult with patients and their family members a lot more frequently, especially during the tougher parts towards end of life. So again, it worked very, very well, and it continues to work very well. For radiation oncology services, when I discuss it with my colleagues, they always tell me that, and again, I'm not a radiation oncologist, I'm a medical oncologist, so they tell me that yes, they can consult online, but that patient does have to come in for simulations, and they have to come in for the treatment planning. So they come in for that one visit, and during that visit, they will be seen by the radiation oncologist. And then when they come in every day for their radiation therapy, again, they'll be seen by radiation oncology. So I think they've developed some form of a hybrid model for themselves, which seems to be working, which is more in person rather than online, as far as I know. For the surgical services, I have to say, it's a bit of a black box for me. I cannot comment to it. I think they've also developed some sort of a hybrid model, but most of the time, I think they do need to examine their patients, and so that physical consultation is important. But they tell me that they're trying to develop a hybrid model.
Dr. O'Mahony.
Sorry. So I think that palliative care for us, sort of has had its challenges because of obviously the barriers that are available. They have maintained telephone triage, but they have not adopted telemedicine in general. I think it is something that is going to have to change. I think what is interesting in radiation oncology that they've seen it as an opportunity, that they've been trying to balance the both on-site and off-site interactions. They are doing a lot of they will do their evaluations with the patients, sort of prior to their coming in, and reducing or improving efficiencies of the time spent actually within the units. I think it has allowed greater optimization of clinic hours when you have to think of a workforce that has commitments outside of work itself, that have to try and balance, sort of children or elderly relatives or other aspects of their care. So we've looked at expanding, not only expanding our day, expanding into 7 days a week, and so I suppose we've seen it as an opportunity to try and find a better balance for all of the individuals.
Good. Dr. Bariani?
Oh, I just want to compliment that we have developed a palliative care program in my practice and have tried to implement telemedicine in palliative care, but the preference for patients is still ongoing with having face-to-face consultations. And I think this may be due to the nature of the consultation. However, we have used some tools online in virtual consultation in a more hybrid way. Consultations with surgeons and radiologists migrated to virtual mode only for follow-up consultations.
Okay, great. Another anecdote, one of my surgeon colleagues, they did much of the pre-op evaluation by telehealth and met the patient for the first time at surgery, and he said, whoa, now I know what a BMI of 45 meant. Whereas he learned to look at the vital signs rather than at the patient. So one of our listeners also, and I'd like to ask on why teleconsult had moved to in-person. I think specifically responding to Dr. DeWood's question, but more importantly, and several of you touched on it, especially moving to 7 days a week. Gee whiz, that's exhausting. So can we speak to is the revenue model driving this change from teleconsult to in-person? Is the physician don't like it driving the change? Is it safety? And how are we going to deal with our workforce exhaustion? Or maybe everybody loves 7 days a week, 8 hours a day. Anyway, so we've got 6 minutes left. Let's go, Dr. Mahoney, Dr. DeWood, and Dr. Bariani.
So to answer the extended working day and the extended working week, I think it's important that you ultimately have to have an increase in resources. So we're looking towards an increase in staffing levels. We at the moment are, sort of similar to everybody else, making, sort of significant business plans with regard to all of the staff that is required to intervene. I think what is interesting in this regard is that patient's preference, and in the patients in whom we have discussed this with, they would say that they like the hybrid model. They would say that their communication with the team has expanded hugely because we are having continued reevaluations with regard to whether it be by telephone, telemedicine, and then in person.
Dr. DeWood?
So my question to you, Doug, is aren't we already working extended hours as medical oncologists? We're working 24 hours a day, 7 days a week. But coming to the point, I don't think that we're going to move into a 7-day-week program simply because I don't think, like Dr. Mahoney very clearly pointed out, it requires resources, and until those resources are in place, it won't be a workable solution. I do think the future holds a hybrid model, and I think that's what we're going to develop. That's what's going to work best for us. I don't think it's revenue generation that has driven down the number of teleconsultations that has at least that I've seen in my part of the world. I think what has driven it down is the fear that you're going to miss something if you don't examine your patients, the fear of the patient not being physically seen by a physician. There is that cultural difference, like I've mentioned before. But like I said, if we are able to develop a truly workable hybrid model, and educate patients and physicians, that's what's going to be the wave of the future.
Dr. Bariani.
Well, I think I agree with Dr. Mahoney. We need resources, investments, and training in telemedicine. And I commented earlier that changes are sometimes difficult to adopt. In Brazil, we already had the habit of providing our phones to patients, mainly in private services. So this moment only conducts a practice that we already did here.
Okay, so yes, some of us do give our cell phone to patients, but I'm worried that that's not a scalable model. So I guess we should. Any last question? Any last comments from our panel?
So if I may ask a question, while we're on the topic of teleconsultations, we've all assumed that teleconsultation is an online, on the computer type of consultation. But discussing with my colleagues from around the world, and I've had colleagues from different parts of Asia tell me that physicians are actually doing WhatsApp consultations. Now, how workable is that, and do we need to have quality matrix for different avenues of in quotation marks, teleconsultation?
I think this is where Dr. Bariani had mentioned the regulations, credentialing, and training, and I think sort of that's why we've had some difficulties in Ireland with trying to choose the right platform, and I think that's something that's going to be evolving as our experience expands.
Dr. Bariani?
Yes, I completely agree. I think it's now time to put everything together and to standardize our practice. How are we going to use all those devices, all those modalities of care, message, teleconsultations, and how we do best for patients, not in an informal way, but in a formal way that we can measure it, that it turns into quality and a good healthcare delivery.
So maybe we have a simple quality measure, and that is that the telemedicine consultation needs to be visible to all members of the team. Might be a rudimentary but fundamental quality measure. So we're coming to the top of the hour. I'd like to thank you all for presentation and turn it over to MJ for some final remarks.
Thank you, Doug. I'll just quickly remind everyone that ASCO quality program offerings internationally have three components. There's Quality Oncology Practice Initiative, which is an oncologist-led practice-based quality assessment program designed to promote excellence in cancer care. Then we have the COPI certification program, which provides a 3-year certification recognizing high quality of care for outpatient hematology oncology practices. And there are several examples now in various countries, an ever-growing list. We have a quality training program that leverages renowned faculty and coaches to improve patient care by reducing clinical and process variation during 5 focus days of in-person learning and virtual assistance. Next. There's an IASLC partnership with ASCO. IASLC, as you know, is International Association for the Study of Lung Cancer in Brazil and Spain to come up with quality measures in lung and to publish the work product in Journal of Thoracic Oncology, which is their journal. That is just a pilot program which hopefully will expand, and why not leverage us through another worldwide organization that already has its footprint in many countries. So we hope to see it grow. Next. So to wrap it up, I would remind you that there are upcoming webinars on September 29th and October 27th. We encourage you to submit recommended topics to the WebEx survey after this webinar concludes. Recordings will be posted on ASCO's YouTube channel. And finally, a thank you and to all the speakers and our moderator, Dr. Bellini, and attendees. Have a great day.
Thank you all. Bye-bye.
Thank you.
Bye-bye.
Thank you.
Thank you.